Hello and welcome to OffBlueMedical. Today I will give you an easy way to remember the autoimmune related antibodies for the USMLE. So to get started with the anti-nuclear antibodies, which are going to be the ANA associated antibodies, the first one is going to be the anti-nuclear antibody. This is the most common one. So the autoantibody name is going to be anti-nuclear antibody. This is going to be sensitive, but it's not specific. So what does this mean? That means if you screen someone for anti-nuclear antibody, they also call it ANA, and it's positive, then that means they have an autoimmune disease, but we don't know what disease it is. So that means it is sensitive, but it's not specific for just a single disease. So it's often used as an initial screening test. Positivity is a criterion for systemic lupus erythematosus diagnosis. So the target antigen is going to be the nuclear antigens, and it's associated with most commonly SLE, but also with scleroderma, Sjogren's syndrome, juvenile idiopathic arthritis, and dermatomyositis. The second one is going to be more specific for SLE. It's going to be called anti-double-stranded DNA. So the target antigen is going to be anti-double-stranded DNA, and it's for SLE. It's associated with systemic lupus erythematosus, and its presence suggests a diagnosis of lupus. So if you get a question that mentions that there is anti-nuclear antibody positive and anti-double-stranded DNA positive, then that means you most likely have SLE. We also have anti-Smith antibodies, which is the Smith antigen, which is ribonucleoprotein. This is also associated with SLE, and it's highly specific for SLE. So for systemic lupus erythematosus, you have anti-nuclear antibody, which is going to be sensitive, but it's not specific. We also have anti-double-stranded DNA and anti-Smith. The most ones you want to see on the questions is going to be the anti-double-stranded DNA and anti-Smith. When you see anti-nuclear antibody, then that means, okay, this is an autoimmune disease. It could be SLE. It could be, but it could be also another disease. But if you see anti-double-stranded DNA and anti-Smith antibodies, then that means you have systemic lupus erythematosus. The other ones is going to be the anti-Rho and anti-LA, which is also called SSA and SSB. These are associated with Sjogren's syndrome. They are positive with Sjogren's syndrome, and you should remember this, as they are positive with Sjogren's syndrome and also positive with SLE. So anti-Rho, I also called anti-Rho and anti-La, SSA and SSB. They are positive in Sjogren's syndrome and to a lesser extent with SLE. So the anti-Rho SSA target antigen is going to be the RNA binding nuclear proteins. As we said, it's associated with Sjogren and SLE. It's positive in most patients with Sjogren. It's also sometimes associated with subacute cutaneous lupus and neonatal lupus. While as anti-LA, which is the SSB, is also has the target antigen RNA binding nuclear proteins. It's associated with Sjogren, SLE. It's positive in most patients with Sjogren's syndrome. It's usually seen in conjunction with anti-Rho. So you see anti-Rho and anti-LA together. And the anti-U1 RMP, you see this in mixed connective tissue disease. Anti-U1 RMP, the target antigen is going to be U1 ribonucleoprotein. Mixed connective tissue disease is basically SLE and scleroderma and polymyositis. So basically, we're going to have lupus and polymyositis and scleroderma. So how I remember it is that there is LPS in mixed connective tissue disease, lupus, polymyositis, and scleroderma. LPS U1 RNP. You should remember that anti-U1 RNP means you have LPS, which is mixed connective tissue disease, which has features that overlap with lupus and polymyositis and scleroderma. So if you see a disease where they mention features of lupus and polymyositis and scleroderma, then that means you have mixed connective tissue disease. And if they say it's anti-U1 RNP positive, then that means you have mixed connective tissue disease. The anti-centromeres, this is associated with CREST syndrome. So CREST syndrome is the limited cutaneous systemic sclerosis. CREST syndrome stands for calcinosis. You can also say that the C, calcinosis and centromeres. And the R stands for Raynaud phenomenon, Raynaud disease. E, esophageal dysmotility. The S is sclerodactyly, and the T is telangiectasia. Whereas for diffuse systemic sclerosis, we have the anti-SCL70. Okay, SCL here means sclerosis. 70 means a lot. So 70 is a lot, and 70, that means that it's diffuse. So anti-SCL 70, and also called anti-topoisomerase 1. Top means that the top most dangerous one is going to be diffuse. So this is how I remember it. Anti-topoisomerase 1 means that it's the top one that is dangerous. Is it diffuse or limited? It's going to be diffuse, is more dangerous than limited. So the top one that's dangerous is the diffuse cutaneous systemic sclerosis. This is associated with diffuse scleroderma, which means skin thickening affecting trunk and proximal extremities, and you also get renal problems and pulmonary problems. For the myositis specific antibodies, we have anti-Jo1, anti-Me2, and anti-SRP. So anti-Jo1 is basically anti-synthetase. The target antigen here is the histidyl tRNA synthetase. It's also sometimes called autoantibody that's named anti-synthetase. It's associated with both dermatomyositis and polymyositis. It's strongly associated with interstitial lung disease, arthritis, and mechanic hands in myositis patients, while as anti-Me2 is helicase. So how can I remember helicase? Well, helicase reminds me of the DNA structure. You know how DNA is going to be basically intertwined like this. So Me2, just imagine a baby saying, okay, me too. Like, me too, I also want a toy to play with. Like, babies always say, me too, me too, me too. And babies have DNA that comes from their mother and their father. That's combined to make DNA, and you get a baby. So anti-me too is going to be helicase. This is how I remember it. It's a weird way, but it works. It's associated with dermatomyositis, and it's specific for dermatomyositis. It's associated with the classic rash, which is the heliotrope, and Guttron papules. You should look this up. It's pathognomonic for dermatomyositis. And anti-SRP means anti-signal recognition particle or peptide, and it's associated with both dermatomyositis and polymyositis. It's associated with rapidly progressive and severe myopathy. So then how can I differentiate between dermatomyositis and polymyositis if all of these, anti-Jo1, which is the anti-synthetase, and anti-Me2, which is the helicase, and anti-SRP, how can I differentiate between dermatomyositis and polymyositis if both of them have these as positive? Well, you're going to differentiate between them from the name dermatomyositis. Derm means skin. So if you see the heliotrope and Guttron papules, if you see skin findings, then that means it's dermatomyositis. If you see no skin findings, then that means it's only limited to the muscles, and this is going to be polymyositis. For the rheumatoid antibodies, we have the first one, which is going to be also sensitive but not specific, which is the rheumatoid factor. So it's sensitive but not specific, kind of like the ANA, the anti-nuclear antibody, whereas it was positive in SLE but also positive in some other diseases. The target antigen here is going to be the FC portion of the IgG. It's associated with rheumatoid arthritis from its name, rheumatoid factors associated with rheumatoid arthritis, and sometimes with Sjogren's syndrome. And we said Sjogren's syndrome is also associated with anti-Rho and anti-LA, SSA, and SSB. So it can be positive also in cryoglobulinemia and infections and healthy elderly. So if you see an 80 years old male or female that has a positive rheumatoid factor, it could be normal. If you see someone that has an infection with rheumatoid factor positive, it could be normal. If you see cryoglobulinemia and they have rheumatoid factor, that could be a false positive. So it's sensitive, but it's not specific, and higher titers correlate with more severe disease course. And we have the specific one for Sjogren is going to be the anti-CCP, which is the anti-cyclic citrullinated peptide, Target antigen is going to be the citrullinated peptides. So how I imagine it is I imagine just some protein mixed with lemons, and that's citrullinated peptides. The associated disease is rheumatoid arthritis. It's highly specific for rheumatoid arthritis. So kind of like SLE, where we had anti-nuclear antibodies which were sensitive but not specific. Here we have rheumatoid factor, and the specific ones for SLE were anti-Smith and anti-double-stranded DNA, where here we have the anti-CCP, the anti-cyclic citrullinated peptide for rheumatoid arthritis. It's more specific than rheumatoid factor, and it's useful for early diagnosis. For vasculitis and inflammatory bowel disease associated ones, we have the ANCA ones, which is going to be the C ANCA. This is granulomatosis with polyangiitis. The Wegener, okay, the Wegener has C ANCA. It's associated with granulomatous inflammation, upper and lower respiratory symptoms, and glomerulonephritis. Whereas P ANCA, which is going to be the perinuclear ANCA, is associated with ulcerative colitis, primary sclerosing cholangitis. So it's positive in ulcerative colitis. It also helps distinguish ulcerative colitis from Crohn's disease. So usually ulcerative colitis is going to be positive, and in Crohn's disease it's going to be negative. So you have to differentiate between these, the C ANCA and the P ANCA. The C ANCA is going to be positive in granulomatosis with polyangiitis, and Wegener and P ANCA is going to be positive in the other diseases such as ulcerative colitis and primary sclerosing cholangitis. So you have to differentiate between them, and we also have the anti-Saccharomyces cerevisiae antibody, which is associated with Crohn's disease. It's positive in Crohn's disease, and it's typically negative in ulcerative colitis. So these ones are really, really important, and you have to remember these because they come up all the time. For antiphospholipid antibodies, we have the antibody which is going to be antiphospholipid antibody. It's associated with antiphospholipid syndrome, and it's associated with recurrent pregnancy loss, miscarriage, and hypercoagulability. So you get DVTs, PEs, and miscarriage, and it can also cause a false positive syphilis test. For autoimmune liver and GI antibodies, we have the antimitochondrial antibody associated with PBC, which is primary biliary cirrhosis, and it's highly specific for it. It's associated with cholestasis, hypercholesterolemia, and middle-aged women. We have anti-tissue transglutaminase. It's associated with celiac disease, and this is an important one for the USMLE because it's common. So it has a high sensitivity and specificity for celiac disease. It's used for screening and monitoring adherence to gluten-free diet. You should remember it. Anti-tissue transglutaminase. So in celiac disease you have an allergy to gluten, and you have to eat gluten-free diet. So anti-tissue transglute. Glute should help you remember that you have to eat a gluten-free diet because you have an allergy to gluten. And in anti-gliadin, similar to it, it's basically the same as anti-tissue transglutaminase. It's just another antibody that we discovered. It's associated with gluten sensitivity, but it's less specific than anti-tissue transglutaminase. For the endocrine ones, we have the thyroid-stimulating immunoglobulin. This is associated with Graves' disease. So basically in Graves' disease, we have antibodies that go to the TSH receptors, and they are going to stimulate thyroid production. That's why we have hyperthyroidism in Graves' disease. It activates the TSH receptor, leading to hyperthyroidism and diffuse goiter, and it causes ophthalmopathy, which is going to be exophthalmos. The opposite of that is going to be the antithyroid peroxidase. In Hashimoto thyroiditis, we get hypothyroidism, and The target antigen here is the thyroid peroxidase, from its name, antithyroid peroxidase, and its high titers are seen in Hashimoto. It's also called chronic lymphocytic thyroiditis, and it's associated with hypothyroidism. The antithyroglobulin is also seen in Hashimoto thyroiditis, and it often co-presents with antithyroid peroxidase in autoimmune thyroiditis, and that is Hashimoto thyroiditis. We also get islet cell antibodies. This is specific for type 1 diabetes mellitus. We get antibodies that go and attack the pancreatic islet cells, and it means that this is a marker of autoimmune destruction of beta cells that produce insulin, and is going to distinguish type 1 from type 2 diabetes. In type 1 we have it, in type 2 we don't. In type 1 it's basically an autoimmune disease that destructs the type 1. In type 1 diabetes mellitus, it's an autoimmune disease that's going to destruct the beta cells that produce insulin, whereas in type 2, it's basically we have insulin resistance. For the neurological ones and the neuromuscular ones, we have the anti-acetylcholine receptor. It's associated with myasthenia gravis, and this is important. The target antigen is going to be the nicotinic acetylcholine receptor. It causes postsynaptic blockade at the neuromuscular junction. It's associated with ptosis, diplopia, and weakness worsening with use. So if you get a female, maybe in her 40s, 50s, where she has weakness and she has a double vision at night, and on testing the muscles weaken and they worse with use, then you have myasthenia gravis. What's going to be the autoantibody is going to be anti-acetylcholine receptor. That is the antibody that's targeting the nicotinic acetylcholine receptor. The other one, which is a similar one, is going to be the LEMS, which is Lambert-Eaton myasthenic syndrome. It's also spelled like this, LEMS, anti-voltage gated calcium channel. So this is going to be presynaptic, whereas myasthenia gravis was postsynaptic. Here it's going to be presynaptic calcium channels. So this is a paraneoplastic syndrome, sometimes associated with small cell lung cancer, and this is very important. Weakness improves with use. So if you get a middle-aged male who smokes a lot and on X-ray has a coin-shaped lesion in his chest and has weakness that improves with use, then this is going to be Lambert-Eaton myasthenic syndrome. Which autoantibody is it? It's going to be the anti-VGCC, voltage-gated calcium channel. This is the presynaptic one. It's not the postsynaptic one. Presynaptic is LEMS. Postsynaptic is myasthenia gravis. For anti-aquaporin 4 channels antibodies, and this is for neuromyelitis optica. This is diagnostic for Devic disease. It's also called neuromyelitis optica, Devic disease. So in Devic disease, you basically get optic neuritis and transverse myelitis at the same time. The other one is going to be the anti-myelin oligodendrocyte glycoprotein. This is MOG, anti-myelin oligodendrocyte glycoprotein, MOG. It's associated with optic neuritis. Patients may have a lower risk for developing multiple sclerosis compared to those without the antibody. This is more of an obscure one that you should just be familiar with, whereas the other three are very important. The first two are very important. The third one is very, very important for step 2. The last one is going to be an obscure one that you should just be familiar with. The renal ones and the hematological ones, we have the anti-glomerular basement membrane, and this is associated with Goodpasture syndrome. The target antigen is going to be the basement membrane. It causes nephritic syndrome, which is rapidly progressive glomerulonephritis, and pulmonary hemorrhage, which presents as hemoptysis. Anti-glomerular basement membrane. The other one is the immune thrombocytopenic purpura one. Immune thrombocytopenic purpura. Thrombocytopenic means we have low platelets. Then that means we have antibodies that destroy these platelets. This is going to be the antiplatelet IgG. This is GP2B, 3A, and it causes platelet destruction in the spleen. Patients present with thrombocytopenia and petechia. With direct antiglobulin test, it's also called the Coombs test. The target antigen is going to be the RBC surface antigens, and we see this in autoimmune hemolytic anemia. So this detects antibodies or complements that are bound to the RBC surface, positive in autoimmune hemolysis and hemolytic transfusion reactions. So basically, if a question says direct antiglobulin test or Coombs test is positive, then that means you have an autoimmune hemolytic process going on, or you have a hemolytic transfusion reaction that is going on because of preformed antibodies